And settle in, and we're going to get started. Welcome to the Applied Learning discussion on documentation and supervision in practice. My name is Alam Elbadou, and I work for CASA Columbia, MCTAC. I do have a possible co-presenter today, Carla Licio, but for the most part, you'll be hearing me.
Hello, everyone. This is Carla.
I do want to encourage all of you, if you have any questions at all, feel free to chat it into the box. What we'll do is collect questions and be able to gather information for you and get back to you in a concise manner. So feel free throughout the discussion, if you have any question about any of the material, feel free to chat it in. Okay? So with that, we're going to start. So who is MCTAC, and what is MCTAC? MCTAC is a training, consultation, and educational resource center that offers resources to all mental health and substance use disorder providers in New York State. And our goal as MCTAC is to provide training and intensive support on quality improvement strategies, including business, organizational, and clinical practice to achieve the overall goal of preparing and assisting providers with the transition into Medicaid managed care. And who is MCTAC? MCTAC is made up of McSilver Institute for Poverty Policy and Research and CASA Columbia. Okay. So MCTAC has several partners, as you can see here on the screen, and the partners are made up of a wide range of both advocacy and provider agencies, which not only provide a wide range of expertise, but also a vast geographical footprint within the state. Okay. So now that we have an idea of who MCTAC is, for those of you who did not know, we're going to start with some of the learning objectives that we're going to talk about today throughout our discussion. So using the case example from our first ALD, for those of you who have tuned into that, we're going to talk specifically now about documentation and supervision. So for the documentation portion, we're going to be connecting the dots of utilization management, medical necessity, and overall documentation. We're also going to be discussing why documentation is so important in this entire process and what good documentation looks like from the lens of managed care. So making sure that we incorporate medical necessity, evidence-based and best practices, clarity of our notes, and progress towards the goals, and what we're going to introduce is as known as the golden thread. Supervision also in the context of managed care, we're going to delve a little bit deeper on how clinical supervision should adapt using data and outcomes to help supervise, authorizations both pre- and continuing stay reviews, along with documentation, focus on outliers and outcomes and data. So our case example from our first ALD was with regards to Miss Amy Cook. We have a brief summary here that I'll go through. She's a 28-year-old divorced African-American female. Her diagnosis is alcohol use disorder severe, along with cocaine use disorder severe. The onset of her use was in her teens, although she did disclose being exposed at a younger age due to alcohol being incorporated into her family events. Denies serious medical complications or mental health diagnoses. She did reveal that she had seen a doctor at some point in time who had mentioned hypertension to her, but she had not been managed by any sort of medication or saw a physician for this diagnosis. She presents as oriented and stable. She reported at the time of admission that there was no use in the past 4 weeks. She's completed all but 1 year of high school and has received specialized training as a welder. She's currently employed as a parking attendant. Her financial support comes mainly from her grandmother and minimally from her employment. She does report some legal issues. She stated that she has had 3 DUI charges, along with possession and prostitution charges, and she is currently on probation. Okay, some more about Miss Amy. She currently resides with her grandmother. She has 4 children, 2 who happen to be in foster care, and 2 that are living with relatives. Amy is not in touch with her children or their fathers. She was previously married for a short period of time, is now divorced. She revealed that she has a history of SUD in her family, both her parents, some uncles and aunts, and 2 of her siblings. she reports a history of physical abuse as a child, causing her to move in with her grandmother. Began using in her late teens and spending more time with others who did the same, eventually leading her to support her drug habit by shoplifting and prostitution. Okay. Amy reported drug treatment on 4 occasions. 2 of those 4 occasions happened to be in a brief detox for her alcohol use. She reported resuming substance use in a matter of days following each detox episode. Amy's longest period of abstinence had been for 60 days. She has fragmented interpersonal relationships due to continued use, and she reports sporadic participation in AA and NA meetings. Okay, so just to make sure that everyone is clear, that was at the time of Amy's admission. So she reported all of the information we just reviewed, and we collected that through our assessment process. And now we want to give you a brief update as to where Amy is today. Her current physical state is shown to be stable, as she's reporting no use with her chronic, no use and no issues with her chronic medical condition, hypertension. Amy denies any use since her admission to treatment. She reports a sense of improved social well-being as she has expanded her recovery-based network as an immediate result of continuous participation in her treatment sessions, specifically to group, and along with her NA and AA meetings. She states that now this has assisted in keeping her on track. She also reports that her relationship with her grandmother has significantly improved ever since she's been attending treatment. Amy reports her emotional state as being happy again. She explains feeling excited about opportunities she sees ahead of her since refraining from the use of alcohol and cocaine. She's hopeful about her future and feels like she has a purpose again and that she will accomplish all the goals that she has set out for herself. Amy has continued to work with her counselor and probation officer to ensure all of her legal responsibilities are taken care of and addressed. She denies feeling anxious or sad about her legal issues like she once did, and she's actively playing a role in tackling her legal stipulations. She's actively participating in her recovery through groups, individual counseling, and her 12-step meetings. She hopes that her schedule will become less busy so that she can really focus on finding appropriate employment. Okay. Amy was originally admitted to intensive outpatient. Her original schedule was she was attending group 3 times a week and seeing her counselor 1 time a week for individual therapy. Amy has made gains towards achieving her goals. Her counselor and the team believe that she is likely to be ready for a lower level of care, and so her counselor will use the locator to assess for this. Okay, so how does all of this get documented? Here's the golden thread that we were discussing earlier. So as you can see, there's a couple categories here of documentation, including assessment, goal setting, service plan, service delivery, and discharge. And the golden thread specifically refers to the progress notes that should be the link back to the goals, objectives, and in the service plan. So you always want to make sure that they're referenced. So what is documentation? A brief explanation of documentation is a record of the need for treatment, the interventions that constitute the treatment, and the client's response to those interventions. The opportunity to actively involve the client in treatment and capture their view of progress towards recovery. It demonstrates medical necessity, and if it is not written down, it didn't happen. So we want to keep that in mind. Documentation is key of every interaction with the client. Elements of documentation: use of assessment tools, tracking progress in measurable ways using these tools, describing interventions used in treatment, describing the client's response to the interventions, utilizing client strengths, and incorporating the client's voice all throughout the documentation. Ongoing assessments. So in creating and utilizing the service plan, we use the assessments to determine the focus of the plan. The service plan targets symptoms and areas of identified need that currently inhibit the client's ability to reach their goals. There are a variety of tools that one can use to make these assessments. We've actually jotted down a link that is to the MCTAC website. The tool specifically here that is a directory of these assessment tools that you could reach is called the Outputs and Outcomes. So I encourage all of you to visit this website, and see what sort of tools are available that could serve the purpose of assessment. Okay, so specifically in Amy's case, one possible set of ongoing measures to monitor are her cravings, if there had been any use, protracted withdrawal, mental health status, particularly in light of her trauma history that she reported at assessment, compliance with the criminal justice system, client strengths, client's expressed goals, and perspective on treatment. So all throughout treatment, interventions and client progress is documented in the progress notes. So the progress notes and or the challenges that are encountered should always be documented, referring to specific goals, objectives, and barriers in the treatment plan. Interventions used during the month and how they helped promote recovery goals should be jotted down as well. Any significant life events, both accomplishments and difficulties, along with the description of the progress towards attaining the goals and objectives. And then confirmation that services are being provided as defined in the original plan. So some tips to make sure that our progress notes are comprehensive. You want to make sure that they're including how a person is using the services to achieve these goals, along with it should also not be a general progress, but linked back to the specific goals that have been identified in the plan. It also focuses on actual staff interventions rather than observations of the client, observations of clients, along with the client's point of view to be included within that. It should document all communication with other providers, services, medical professionals, family collaterals, and all care coordination. Progress note tool. Here we have a template that allows clinicians to have guidance on what to focus on. It saves time, and it also increases the likelihood that the provider will discuss long-term plan for discharge. So this is just an example. It doesn't necessarily dictate what the template should look like, but it is just an idea of a sample progress note. So what we have here is, again, just a brief example of what the progress note could look like. So the client's presentation is described as agitated, anxious, hopeless, and ambivalent. New developments and progress made since the last session. Amy found a home group that she enjoys being a part of, referencing her 12-step groups. She's also identified some financial difficulties that have become problematic since her hours at work were cut, posing challenges in continuously working towards her goals that involve transportation, needing to get from point A to point B. Interventions and clients' response to these interventions. So we scheduled a family session with her grandmother. Client seemed eager to get assistance in negotiating family relationships. She's practiced relaxation techniques in session to reduce her anxiety, along with reviewed her self-monitoring techniques to reduce catastrophic thinking and checked for relapse potential. And the plan for the next session, check for an update on relations with grandmother and ease of getting to the meetings, and continue to work with Amy on positive coping strategies.
Oh, this might be a good place to pause for a second. So essentially, before we move on to the rest, it would be an opportunity here to take a minute and think about how progress notes may be written in a lot of different styles currently in your organization. I know for myself, I have certainly seen lots of really good clinicians delivering really good service that you would never know that that was happening based on the progress notes. And the importance of this is that when you go to a managed care organization to advocate for why your treatment is working, if you don't have demonstration of what you're delivering and how it's working, it's hard to get a really good conversation going with a managed care organization. In addition to that, really good documentation is a reflection of really good quality work. And that's what you're delivering, really good quality work. Don't shoot yourself in the foot by not documenting what you're doing. So this sample progress note identifies, this does not tell a story about what happened between Amy and her grandmother. It tells the story of what happened in the session and what is happening in Amy's treatment. And that's the story you want to be telling. You want to tie it back to the goals and objectives. You want to identify clearly, precisely what the interventions are, and you want to talk about what the response to that intervention was to demonstrate, this is the work I'm doing, this is how the client thinks about the work we're doing, this is how the client's responding to the work that we're doing, and this is our next step. So I just wanted to bring that sort of overarching view before we moved on. Thanks, Alam.
Great point, Carla. Thank you. Okay. So with that said, we're going to move on to the role of supervision. So we want to discuss the specific role that the supervisor plays in all of this. So individualized service plan and services. We want to make sure that they're not necessarily cookie-cutter approaches, right? So you want to make sure that the service plan represents the individual. We want to continuously keep the person-centered concept in mind. So again, based on the golden thread, you're looking at the assessments, goal setting, and treatment planning. The MCOs will look for the evidence of the individualized care, and supervisors need to track this. So just a brief reference to Amy. Amy's counselor, Jean, meets with her supervisor weekly to ensure that all is on track with each of her cases that she has on her caseload. So by presenting the case to her supervisor, including any updates throughout the time that she's seeing Amy, is helpful to Jane and is helpful to the supervisor to kind of stay in the loop on what's going on. Also ensuring that the treatment administered to Amy is based on what she had reported at the time of assessment and incorporates any updates to her goals that she's made throughout her time in treatment. And her service plan addresses clear and concise goals that are in fact measurable. Okay. Do clinicians have the support that they need? So your role as a supervisor, you want to ensure that your staff has the appropriate tools to utilize in order to continuously provide quality care. So again, do they have the support that they need, the professional development opportunities, the basic understanding of managed care and what managed care is all about, a script for discussion with the MCOs, and trainings perhaps specific to best practice or evidence-based practices. And also you as a supervisor, do you have what you need? Do you have a clear understanding of what your role is and technical resources such as the EHR or something equivalent to that? And along with other supports such as tracking visits, authorizations, and data outcomes as well.
I want to jump in again. This is Carla. I think that I can't emphasize enough that utilizing some technical supports or data in supervision will be really important. And some of you may be doing that now, and for some of you this may be new. But this is the information. We're going to ask our staff to work from a data-driven perspective. Supervision needs to reflect the same. So when you're working with your supervisee, you need to be able to pull up their information. What is how many visits are they averaging? What is the goal attainment on average for this particular clinician? How are they measuring up with outcomes that you're looking at? How does their caseload do as they come through treatment? These are the kinds of pieces of information that you'll want to speak to within supervision. Of course, that doesn't preclude, nor should it not allow you to make room to have the really important clinical conversations that are needed to make sure that if you've trained clinicians in evidence-based practices, that they are remaining faithful to the model, that they are utilizing best practice at appropriate times, that they're not ignoring particular aspects of a client's presentation in their treatment plans and in their interventions. So again, for some of you, this may be something, utilizing data is something that you're doing now, but if you're not, this can be an opportunity to transition to that type of supervision.
Absolutely. Thanks, Carla. Okay. So also as a supervisor, reviewing the documentation on the existing clients, focusing on ensuring that there is clear, concise language within the notes and all the documentation in the chart, that the notes are actually complete, and that they reflect medical necessity. The progress notes reflect goals and objectives, and make sure that the process is in place for any new clients. Okay, some next steps. Understanding your team's caseload, ensuring that you have a general idea of what's going on, if there are any high-profile clients that, that your clinicians are dealing with that, in fact, could use a little bit more attention. Maintain the calendar for any kind of reauthorization schedule. Make sure that the charts and notes show quality, medical necessity, progress or reason for lack thereof, and that they're up to date. Making sure that there is an organizational plan for who speaks with the MCOs and that they're prepared to offer the necessary information for any kind of authorization that is in fact needed or required. Some additional general tips. The writing should be clear. Not all details, just important facts. So you want to make sure, as Carla mentioned, you want to talk specifically on what's happening in the session versus the story that the client may be telling. And again, it's not the story of the client. We want to make sure that we're touching base on anything that's happening within the session between the counselor and the client. Documentation should be appropriate for the duration of services, and document all communication with collaterals and other providers. Collaborate with the client to enhance the person-centered practice, making sure that they have an investment in their treatment plan, in their sessions, that they are an active participant in that. And avoiding auto-populate or cut and paste mistakes, which sometimes happen in the rush of the day-to-day, but making sure that the writing is in fact reflective of the client that you're seeing and making sure it's individualized. Making sure that the documentation is completed in a timely fashion, and keeping in mind that there's still a need to satisfy state regulations through OMH and OASAS. Okay, so some questions that your documentation really should be able to answer. So the MCOs are going to be targeting specific areas or information that they're looking for. So some of these questions could serve as an example for that. So how will the treatment impact Amy's individualized psychosocial needs? So you want to look at why is this treatment necessary? You want to be able to justify that and provide an explanation as to why this person is in this level of care and why they need it. What else can be tried and why hasn't it been sufficient? So you want to talk about maybe perhaps the client's experience in other levels of care. Would she be able to be successful in a lower level of care? Why or why not? What will be accomplished by this treatment? How does this treatment fit into the bigger picture of Amy's recovery? And how will you know when a treatment goal has been in fact achieved? Again, we want to highlight the measurable goals that you are consistently keeping track of throughout the course of treatment. And what are you looking for, and how will you monitor it? So you want to be able to spell these things out and be able to identify them easily. What strengths and support does she have that will facilitate discharge and transition to a lower level of care and recovery? Where is the evidence that recovery goals are member-driven? Is Amy willing to participate in rehabilitation activities? What is the proposed time period for the treatment plan? Again, this reflects back to the goals. When you're sitting with a client, you want to talk specifically, you want to talk solidified time frames. You want to say within the first 2 weeks, within the first 3 months, so on and so forth. You want to provide clinical justification with measurable goals and objectives. And are there anticipated barriers for treatment success? And if in fact there are, what can be put in place to address these barriers in order to be prepared? So with that being said, we're kind of winding down here. I do want to mention that if anybody has any particular questions with regards to the material or anything that we've discussed with regards to supervision and documentation, feel free to chat that into the chat box at this time. And if for whatever reason maybe you think of something later down the line, on this slide that you see on your screen, there's a specific email that you can send MCTAC any sort of questions, and we'll be able to get back to you via email. And that email address is mctac.info@nyu.edu. I also want to make a plug for the remainder of the webinar series. We do have two webinars coming up in January. January 5th would be the client education and family engagement on the 12th of January. So please feel free to tune into those. If you have not yet registered or are interested in registered for them, please feel free to go onto the MCTAC website. That's where you can sign up for any kind of updates, any sort of event announcements, and along with access to multiple resources to perhaps any upcoming trainings or trainings that have been recorded as well. This presentation has been recorded and also will be posted on the website for your reference in the event that you have some additional questions. You can always feel free to tune into that as well. With that being said, we're going to wrap up our session. This is with regards to the OASAS side. You have the mental health portion coming up at 1 p.m., so please feel free to tune into that. And thank you so much for spending a portion of your afternoon with us. Have a great day.